everyone, my name is Jana Tumaliwan, a registered nurse based in Germany. So for today, I would like to discuss to you about external ventricular drainage, or what we call EVD. So what is EVD? An external ventricular drain, also known as a ventriculostomy or extraventricular drain, is a temporary method and a device used in neurosurgery that has the ability to drain blood and CSF to mitigate intracranial hypertension, continuously monitoring intracranial pressure, and instill medications. So this method is intended for patients with acquired brain injury such as intracranial hemorrhage with intraventricular extension, subarachnoid hemorrhage, traumatic brain injury, bacterial meningitis, and hydrocephalus. These conditions are associated with increased intracranial pressure, or what we call intracranial hypertension, that is above 20 millimeter mercury due to obstruction of cerebrospinal fluid outflow. So what is the normal cerebrospinal fluid, or CSF? CSF is cerebrospinal fluid production is approximately 0.2 to 0.4 milliliter per minute, or 500 to 600 milliliter a day. CSF is circulated along the ventricular system into the subarachnoid space and then absorbed in the venous system within the arachnoid granulations that line the convexity of the brain. An equilibrium exists between an equilibrium normally exists between its production and the absorption. So a disruption of this equilibrium that is caused by intraventricular bleeding or intraventricular blood can cause intracranial hypertension. So EVD insertion. It is actually a flexible plastic catheter which is placed by a neurologist or neurointensivist and managed by an ICU nurses and doctors. So the EVD catheter is most frequently placed by the way of a twist drill craniostomy placed at the Cosher's point, a location in the frontal bone of the skull, this part, with the goal of placing the catheter tip in the frontal horn of the lateral ventricle, or in the third ventricle. This catheter is typically inserted on the right side of the brain, but in some cases, a left-sided approach is used. And in worst cases, catheters are inserted on both sides. So, EVD insertion. The EVD is leveled to a common reference point that corresponds to the skull base, usually in the tragus or the external auditory meatus. The EVD is set to drain into a closed graduated burette here to a particular pressure level, and this pressure is prescribed usually by a neurosurgeon or neurointensive, and leveling of the EVD to a set pressure is the basis for cerebrospinal fluid drainage. Hydrostatic pressure dictates CSF drainage. So this is how it looks like. We also need to place the patient in 45-degree and maintain this position. And we need also to inform the families not to adjust the bed without any supervision. So this is how it looks like. In this, behind this cylinder here, there's a cable that is connected to a cardiac monitor that allows us to continuously monitor the patient's ICP. So what are the nursing responsibilities handling patient with EVD? Nurses should maintain the leveling of the EVD, which is very important, as prescribed by the neurologist or the neurointensive. we monitor for signs and symptoms of intracranial hypertension by continuously monitoring ICP level, maybe hourly or depends on the doctor's order, and inspecting the entire EVD system and insertion site for CSF leak or maybe infection, which is known to predispose infection. Monitoring cerebral perfusion pressure is also one of our responsibilities. And I forgot to include that we also need to monitor the patient's pupil reaction, pupil size, and yeah. So what is actually is ICP? So ICP or intracranial pressure is the pressure inside the skull. It is affected by the brain tissue, cerebrospinal fluid, and blood. So the normal range for ICP is 5 to 15 millimeter mercury. If it increases to more than 20 millimeter mercury, structures in the brain may be impacted and cause stroke. So what we need to familiarize ourselves for the signs and symptoms of elevated ICP. So first is severe headache. Why patients have severe headache? It is because one of the first structure to feel the strain of increased ICP is the tissue called the meninges. And this meninges that surrounds the brain can fire up pain messages, and that result to a terrible headache. So changes in behavior may also be noticed: nausea, seizures, vision changes, and vomiting. So what are the complications of untreated increased ICP? First, the left hemisphere of the brain is separated to the right hemisphere of the brain by a tissue called falx cerebri. So if bleeding occurs here in this part and is enough to push the right hemisphere via falx cerebri, brain damage and stroke can occur. So because of crushing brain tissue and the blocking of the blood of the brain blood vessels. And on the other hand, the cerebellum is also separated from the rest of the brain by the tissue called tectorial membrane. If the pressure builds up above this membrane, brain tissue can be pushed down through the small opening near the brain stem, causing irreparable brain damage. And we need to prevent that from happening, because it will cause paralysis, coma, and even death. So one of our responsibilities is to monitor cerebral perfusion pressure. What is CPP? It is the amount of pressure needed to maintain blood flow to the brain. And CPP is regulated by two balanced opposing forces. These are mean arterial pressure, which is MAP. This is the driving force that pushes blood into the brain. And intracranial pressure, which is our ICP, it is the force that keeps the blood out of the brain. So how to compute CPP? We have the formula. CPP is equals to our mean arterial pressure minus intracranial pressure. For example, we have for example, the cardiac monitor of patient shows our BP of 130/73 and ICP of 14 millimeter mercury. So we use the formula CPP equals MAP minus our ICP of 14, and then we need to calculate the MAP using the formula systolic blood pressure plus 2 multiplied by our diastolic blood pressure divided by 3. So our systolic blood pressure here is 130, plus 2 multiplied by our diastolic blood pressure of 73 and divided by 3. So 2 times 73 is 146. So it will be 130 plus 146 divided by 3. And that would be 276 divided by 3. And our map is 92 millimeter mercury. Then we substitute ICP and MAP using the CPB formula. So we got the result of 78 millimeter mercury. So what is the normal CPP level? It is 60 to 80 millimeter mercury. So our result is 78, so still on the normal range. So what are the complications of EVD? Bleeding is one of the most common complication that can occur along the EVD insertion or in the several insertion tract or in the several layers of the meninges that prohibit passage in the brain. Malplacement of the EVD tube into the brain tissue instead of ventricles can occur in 10 to 40% of the cases. Therefore, computed tomography or CT scan, ultrasound, endoscopy, and stereotactic neuronavigation are used to minimize placement errors of EVD tubes. Obstruction or occlusion of the EVD commonly due to fibrinous or clot-like material or kinking of the tube. The brain can swell due to pressure buildup in the ventricles, and permanent brain damage can occur. So physicians and nurses in intensive care unit can adjust or flush these small diameter catheters to manage medical tube obstructions and occlusions in the bedside care. So infection is also infection can also occur associated with EVDs, and we need to prevent it to become severe, to become a severe form of brain infection known as ventriculitis. So how long can EVD stay in in the patient? EVD is rarely stay in place for more than 14 days. After 14 days or so, the doctor can proceed to VP shunt. That is VP shunt, that is also a catheter and drain to the peritoneal cavity of the patient. And that's all for my discussion for today, and thank you everyone for listening.